So the two case studies that I evaluated were both pediatric patients, the first being a newborn boy who was born at 36 weeks gestation. Dad was healthy at 31 years of age. Mom was 25 years of age and presented with hepatitis B. The child was born severely cyanotic, and ultrasound was performed and determined that he had an abdominal mass on the one lobe of his liver, which was 8 centimeters in diameter, and the child also had complex heart defects. The child died on day 11 due to multi-system organ failure, and the autopsy showed the complex heart defects were consistent with ventricular defects and ventricular septal defects, and the hepatic lobe mass was necrotic and also had extensive hemorrhaging. I think the histology did determine hepatoblastoma, and the second child was born to Russian parents and wasn't evaluated until 6 years of age. Her phenotypic evaluation determined that she had a long tubular nose and that she also had a short gap from the top of her lip to the bottom of her nose, and she had velopharyngeal insufficiency, which gives you a nasally voice. Her EKG also showed a complex heart defect consistent with pulmonary atresia, with a subaortic ventricular septal defect and major aortopulmonary collateral arteries. Surgery was successful to correct this. And at 10 years of age, a flank mass was found, and a right flank mass was found, and a CT showed that it was a Wilms tumor, which there was no other malignancy present, but chemotherapy was recommended. The patient did not tolerate chemo well, but they did have a complete resection, and it was successful. Histology determined that it was a renal cell carcinoma, and the patient was disease-free at 19 months follow-up. In case 1, I would like to believe that the carcinogenic cells that were formed it came from embryonic development, because essentially the child had cancer fresh out of the womb, which is sad. I do wonder, though, if this didn't have something to do with her hepatitis B. And 22q11.2 DS syndrome, the most common feature is usually the velopharyngeal insufficiency, and then also the tetralogy of Fallot or any significant cardiac defect. Typically, it's almost like you have a severe cardiac defect. We're going to get you genetically tested to determine that this isn't what we're dealing with, because if we are dealing with it, we need to look into it further. And with case 2, the child lived overall a healthy life. She was a little bit smaller than average. She had some minor immunodeficiency problems, but there were microvesicles on a lot of her cells. And in addition to that, the microdeletion was present. 22q11.2 DS syndrome is consistent with heart defects and malignant tumors. And I think the malignant tumors thing is kind of just more coming about because you read it in case studies, but you have yet to really find it in your textbooks. But in a lot of the cases for 22q11.2 DS syndrome are sporadic. Very few are actually genetic, and those that are genetic are passed on very, very little. It's a dominant autosomal condition, so only a fraction of the people who get it will pass it on to their offspring. And some of the regions on the 22nd chromosome have tumor-suppressing genes, and I think further studies could be done to implement where exactly the tumors are occurring. And in addition to this, what kind of treatment can we do for patients who have this condition in utero? Is there something we can do fresh out of the gates, or even before we're fresh out of the gates? Can we, I don't know, is there a safe drug? Is there a way we can do genetic testing, but can we pinpoint it even just more closely? Can we kind of get a head start on the process? And in addition to this, I think both children, unfortunately with case 1, the mother's health, I really truly believe had a lot to do with the scenario. But overall, 22q11.2 DS syndrome is very complex, and there is no one-size-shoe-fits-all. The disease varies very greatly from patient to patient.